So they asked me to do it.
Yes.
So please pay attention that there are some information in the role player's notes which requires from you to ask some questions which can be considered by some as some sort of history questions. But there is no black and white in medicine, and the management must include that you also ask some questions to the patient in order to understand what could be the best course of action in the management. And these questions which you will ask definitely will include some history information. So when you ask about the history of past attacks, this is considered about as history questions, but still you need to ask them in the management stations, okay? So pay attention to this information. Most candidates are just, confused. So is it a management station or history taking stations? Please pay attention that there's no black and white. You must understand how to do a dialogue with the patient until you make sure that you cover the most important points in your mark sheet. Okay, it's all about the mark sheet. Okay, so let's see. Your introduction was very good. You showed empathy, but please, I felt that you only have one sentence to which you use in empathy. Make them 2 or 3 different sentences in order not to appear as if you are repeating yourself. Okay. You gather important information about the psychological condition, and you did not ask about the medical condition. Please, you did not ask about her social circumstances. This is very important in the patient if a patient is pregnant, and you must ask about the risk. Show that you are a safe practitioner and the issue of risk is always in your mind. So you want to start by talking with the patient and to understand what is the background regarding the risk because of her mental condition. Okay, so you must ask her about the safety if she has ever been used recreation drugs or alcohol and so on. Okay, your explanation was good. The medications, I think you talked about lithium. Did you mention that I didn't hear from you that you mentioned quetiapine. You said that she's going to take lithium and quetiapine or lithium only.
In the beginning, I told her that you'll start the same medication that you're taking, which is lithium and quetiapine.
Okay, good. What are the effects of medications? As I said, this is now the point of controversy. I prefer to stick as what have been always said regarding the side effects of lithium. I don't recommend that you change this as far as I understand. Okay. Can I breastfeed the baby? Everything is good. You said. Now here regarding the formulation. Okay, please pay attention to the following. Formulation is about crystallizing what is the most important points in the condition of this patient, which you are going to focus in your management. It's not a management, okay? You are not going to talk about the medications which you are going to give or admission or etc. You're just going to focus on the main points or main problems which you are going to work on in this patient. So simply there are 2 lines. The first line is the psychiatric condition and the level of risks. Now, this is a 30-week pregnant lady, high risk of developing puerperal psychosis, which carries risk on her and the baby if not managed. So this is the first line in your formulation. The second line is the background information which you need to know or you already know regarding this patient. And this background includes information in the psychosocial and medical condition of the patient. So you can say something like always on the background that you have been admitted twice under the Mental Health Act because of the puerperal psychosis. You have good support and no underlying medical disorders. How did we know this information about good support and no underlying medical information? Because in the start of the station, you gathered the biopsychosocial information regarding his psychological, medical, social, and level of risk information. Okay, are you with me, doctor, so far?
Yes, sure.
Any question? Okay, so
no.
Regarding the management, when you reach the management point, most probably you will have not more than 96 90 seconds maximum, or if you are very clever, 2 minutes, no more. So you must be very organized in order to make sure that when you talk about the management or the steps which you are going to do in order to take care of your patient will cover the most important points in the management. As for me, I like to start by saying what am I going to do and where the patient is going to be treated. This is a very important point because there is a big chance that this patient might be in need for admission. Okay? If there are any concerns about her safety, you must put the option that she might need to be admitted. You don't know that even if you are going to give her medications, this does not mean that she will be safe. You just want to make sure that she is going to take the medication in the hope that it has controlled her before, but still there is a chance that she might be relapsed. So you must say this to the patient, that she's going to be followed up in the clinic. A nurse is going to be follow her up at home. However, if there are any concerns regarding her safety, the admission to the hospital can be considered. So the first point when you talk about the management is what are you going to do and where the patient is going to be treated. And where the patient is going to be treated, this differs according to the scenario of the patient, of the station. Number two, the investigations. This is the second point. As long as there is some sort of medications, you must talk about the investigations. Did you mention the investigations, doctor?
Now, in the beginning, I mentioned that we will do some medical tests.
No, please, please. And again, this is a very common mistake. What are the medical tests or blood tests? There are hundreds, literally hundreds of blood tests. So you must specify what are the blood tests which you need when you start a patient on any medication. So these are the routine blood tests: the liver functions, kidney function, complete blood count, blood chemistry, and lithium levels. Okay. So, and then you mentioned a very important point that she's going to be followed up by the perinatal team. You must mention this team because this is the team who is supposed to take care of a patient who is pregnant and she has a mental health problem. And you must say that we are going a team which will cover all her needs physically, psychologically, and socially under each heading of the physical, psychological, and socially are going to talk a little bit. So regarding the physical, definitely you're going to liaise with her obstetrician. And regarding the psychological, this is the role of medications. You're going to start her on lithium and quetiapine. However, before delivery, lithium will be stopped and the plasma level will be checked after the last dose by 12 hours, and the dose will be adjusted accordingly. Okay? Regarding the social support, okay. Now, particularly in this station, there are two questions which are posed by the patient and they can just find it difficult to answer. What will happen if I became unwell again after the delivery? This particular question, many patient candidates find it difficult. So rest assured that this probably is planned for. It will be closely followed up by perinatal team, etc. Number two, what will happen if she started to have labor before the section date? So simply, she has contact numbers for the emergencies and inform the obstetrician that if she is going to go suddenly to do delivery, she must inform the obstetrician about her mental health needs in order to make sure that the mother and baby are going to be safe after the delivery. Okay, and they must stay in the baby unit and they must contact the perinatal team. So these two questions, which the candidates find it troublesome in this particular station. And determination, I will give you a leaflet about all what we have discussed, etc. So let's see according to our mark sheet and pay attention because it's all about this mark sheet. Though Dr. Amr is very clever, but unfortunately, the first point is not going to be scored for him because he couldn't formulate. And even I gave him another chance. It seemed that the skill of formulation needs to be
It's completely lost.
okay. First is no, he recognized all the findings. significance of the findings in the Candice knows. His management plan was very well. Does not pay sufficient attention to the patient health. You know, you paid attention to what I'm saying. Risk management plan, it was good. Psychological and social intervention, I think everything is okay here. Regarding your communication, it was good, but still, because you are repeating some sentences, I think there are 2 points related to the language here, which are not fair for the candidates who are international medical graduates, but they are related to the language. So if the consultant felt that your language is not good, so you might lose these 2 questions if you are repeating the same sentences or you have problems in your grammar or etc. So these 2 questions, 2 points might be lost for you. You are repeating some sentences, some empathetic sentence in the same manner. Please try to use different sentences. As far as I can say, your performance was good. I'm not a consultant to say pass or fail, but I'm just giving you some idea about the points which you should work on and how to assess yourself by this mark sheet. Now, I hope that you found it difficult. I found it helpful.
Thank you, Dr. Hussein. Many thanks.
Well done. Conversation and focus on the patient preference. Well, I don't understand, Dr. Sarah, what do you mean by the patient preference? As far as she has been controlled by only 2 medications and there is high risk in the past 2 admissions. What do you mean by patient preference? I don't understand. Okay. So who would like to go next?
I can go next, please, Dr.
Yeah, Dr. Noura are required to go next because she has some sort of...
So I actually mentioned that I want to do the first station and it's already 12 a.m. in India. I have to work as well tomorrow. So I let the first station go. I thought it's according to the sequence, but I would really like to do my second station.
Okay, Dr. Noura, it's 12 a.m. Can you give her a chance? No problem. Okay. Well, Dr. Noura gave you kindly. Thank you so much.
So much. Thanks a lot.
Yes, we are all here helping each other. Okay, so Dr. Eugenia, is it right to say?
It's Anisha, sir. It's the first one, ADHD management.
Dr. Anisha. Okay, so what is your station?
The first one, sir, the ADHD management one.
Okay. Can you see the station?
I can only see the heading, not anything else after that. Yeah, now it's moving. I'm good to go. So we can start, I think.
Okay. Very clever. Okay, let's say that my name is Mrs. Green, the boy's name is Robin. We'll start now.
Hello, Mrs. Green. I'm Dr. Anisha. I'm a psychiatrist here in the mental health unit. I have my notes here that you're really concerned about your son, Robin. Can you tell me a little bit about what's concerning you today?
Well, doctor, I have read that about the ADHD diagnosis, and I did some search, and I want to know exactly, he has been diagnosed with ADHD. What is the management which is suitable for him?
All right. I really understand you must be quite concerned. It's not really easy. So I'll try my best to help you with the diagnosis and all the doubts that you have. So ADHD is an illness which is basically called attention deficits or hyperactivity disorder, or we generally also call it hyperkinetic disorder. It's a disorder which is fairly commonly seen in young children up to the age of 12, although it can persist after that as well. So as Robin is 5 years old, it's possible that he has the diagnosis. It's also seen that it's particularly more common in boys than in girls, almost 2 or 3 times more than what we see in girls. Are there any particular things that you've noticed in Robin, since you said you've read about ADHD?
Is it a common problem, doctor?
It's not uncommon. It's something that is seen in the population. If we talk about the general population, there's a possibility of 1.5 to 2% of the population kids suffering from ADHD. So it's not uncommon, and definitely more commonly seen in boys. And there are particular symptoms that are very consistent with ADHD, which include that the child might be really hyperactive, very fidgety, not really able to sit at one place, have this difficulty in concentration. So there might be some complaints from school that he's not able to finish his notes. And sometimes they do indulge in very impulsive activities or things that they don't realize are risky. Have you noticed Robin has been indulging in any such activities that I've mentioned?
Yes. He's very active, always on the go. Yeah.
Right. So that must be quite hard for you.
Well, doctor, his father also has ADHD, and I'm 8 weeks pregnant. What are the chances of having a baby with this disorder?
So, you're right. If his father has ADHD, there's definitely a genetic component to it. People who have family history of ADHD, they're more likely to get ADHD. So if your one child has ADHD and you're pregnant again, the chances are that this child is at a greater risk, maybe 2 to 3 times greater risk of a person who does not have a family history of ADHD. We can't know for sure. There is no test to tell you for sure if your child would be having ADHD or not, but there's a definite increased risk.
I see. What are the causes of the ADHD?
Yeah. So again, this is also quite complex, as we discussed that it can be genetic, because if a family member has ADHD, you're more likely to get it. Other than that, there are multiple things like having maybe, a stressful birth. Some maybe the mother using any sort of substances like alcohol during a pregnancy, or having trauma during birth, or having certain infections during birth or during pregnancy. But we cannot short say that what would be the cause in a particular person to develop ADHD.
Could be there any blood tests to diagnose it?
Unfortunately, we don't have any blood test right now, which can actually tell us if a person has ADHD or not. We have to moreover go by the symptoms that a child has.
Okay, do you think that he's going to get better?
So we can, to say that if he's going to get better or not, we'll have to see how we can help him, and we need to provide him with a formulated plan which can make or increase the chances of improving better. Do you have any other concerns regarding ADHD, or we can talk about management?
Well, yes. How are you going to help him?
Okay, so before we talk about management, I'll just cover a few important points that we've discussed. We've discussed regarding Robin having a diagnosis called ADHD, in which he's quite hyperactive, impulsive, and has difficulty in concentration. And it is genetically, you have increased chances if there's family history of ADHD. Apart from that, it is difficult to manage sometimes because of the attention problems, and it can be difficult for the child to manage. So the illness needs to be definitely managed. When we come to the part of management, there are multiple ways by which we can help Robin. The first one be medical management. But before going to that, we need to do certain investigations. Like, because if you're thinking of starting him on medications, we need to have certain blood tests, like a basic blood count, his liver functions, heart tracings, and his BMI, of course, to be sure that we can go ahead with the treatment. Once we are done with the investigations, we can think about starting him on something called as stimulants, which are basically medications. Now, as we discussed that ADHD is related to a brain problem. There is a certain molecule called dopamine, which is in the brain, and to sort of balance that chemical in the brain, stimulants can be helpful. The most commonly that we use is methylphenidate. Are you following me till now?
Yes. So are you going to give him a stimulant? How come?
Sorry?
How come you're going to, he's already on the go. Are you going to give him stimulants? How come?
Yeah. So the stimulant would not be stimulating him or making him more active. It's supposed to control those problems of impulsivity, control the problems of being hyperactive. Regarding what dose that we use will depend once we assess Robin again properly. And we see according to his weight and the severity of his problem, we're going to start him on a low dose. And during our continuous follow-ups, we will see what dose is adequate for him. And because of the medications, I'm sure you must be concerned if there are any problems or any side effects with the medications.
I see. Okay. Is there
Concerned.
any particular special diet for him?
So there's no particular diet which we suggest that you should take if you have ADHD, but definitely preservatives, a lot of caffeine, these sort of substances are better avoided. Any other doubts that you have regarding the?
How do you feel about what you did? Time. How did you?
I didn't see the sign of 1 minute. I was still going to cover educational part for the parents and the psychological part and the putting them into the social and the psychological management part.
Okay.
And side effects of methylphenidate.
Okay, so well, it seemed that you were lecturing too much and you wasted time in this lecturing. You must have better time control. I hope that you give her some sort of feedback. Okay. So how do you feel about what you did, Dr. Sanjay? How do you feel about how do you feel about, give us your feedback, your own feedback about what you did?
I missed, I think it was, I don't know what could I have shortened because all points were to be covered.
So when you started explaining the ADHD, I think you missed the symptoms of the ADHD and you started to talk about the symptoms later on. When I asked you, is it common or no, you gave me the prevalence, but you covered, while you are talking about the prevalence, the symptoms of ADHD, which I think this couldn't be considered as disorganization. Will he get better? This is a question about the prognosis, and this is a question about do you know the prognostic factors or no? Formulation, I did not get the formulation. Unfortunately, you are lecturing, avoid lecturing, please. When I ask you if the patient is going, how come you are going to give him a stimulant while he is already active? The best answer is by saying that this particular medication stimulates the centers in the brain, which helps the attention and the concentration. So this will help the patient to be more attentive and to concentrate better, and eventually will improve his condition. Okay.
Yes, sir.
Let's see according to the notes. So your introduction was good. Your explanation was very good. So it is developmental disorder, 3 times more common among boys, exactly like what you said. I wrote the notes when the nosology was talking about the age of 7. Did they change it now? It became 5.
So the age of the child was 5, but I mentioned up to 12 because the nosology is now, it says before 12.
Okay. So it causes a degree of a problem in the attention and the concentration and hyperactivity and impulsivity, and that it affects the areas of his life like the education and so on. So it's not all about talking about problem in the attention, but you must say that it is starting to have a negative impact on his life. Is it common? These are the figures from the NHS. It is 1 every 20 children. It affects 3.5% of boys in UK and around 0.85% of the girls. Okay. His father has, now these are the troublesome questions. So the father has ADHD and the father with the baby, and she is pregnant, and she wants to know the chances of having a baby with this disorder. So we must talk about some statistical figures, which I have gathered. I did my search, and you'll find it only here as far as I know. So the disorder, it is a disorder which runs in families. So 3 out of 4 children have ADHD, has a family member who has ADHD. And the risk increases with the increase in family members who have this disorder. So this means that her new child most probably will have a high risk because he has a brother and a father who has ADHD. And roughly speaking, anywhere from 1/3 to 1/2 of the parents with ADHD will have a child with a disorder. So if a parent has an ADHD, if 100% has ADHD, most probably 1/3 to 1/2 of them will have children with ADHD. Okay? And if there is a sibling with this disorder, the chance of having another sibling is 30%. Okay? So this is how you answer this question. A lot of statistical figures, but if you just have a look at it, you will understand it's not that difficult. Now, what are the causes of ADHD? Please pay attention. I think your answer should be improved. So as we know, family members, alcohol intake and smoking, very important. A low birth weight and preterm delivery, exposure to toxins, head trauma, and chemical imbalance in the brain. These are the most common causes of ADHD. Again, a family member, alcohol intake, smoking, low birth weight, and preterm delivery, particular toxins like lead, head trauma to the baby. And you know, head trauma is very important because they found that ADHD is more common with those who are delivered by this suction. I don't know what do they call it. It's a suction which is put on the baby's head and they just pull him. I don't know what they
Ventouse, something like this.
Yeah. And the delivery, the obstetrician used some sort of some instrument is put on the head of the baby.
I think it's called ventouse.
Ventouse, yeah. Ventouse. Okay, are there any blood tests? It is mainly a clinical diagnosis. Now, the question is, will he get better? So it is very important to pay attention that this question would help you to answer 2 questions. The question which is already answered, will he get better? Which is a question about the prognosis and also the formulation. So before answering this question, you must gather some information because this information will help you later on to do the formulation. So you want to know more about the social circumstances, the physical and the level of risk, and then you set your the prognostic factors. So we know that there are some factors which help us to predict the outcome of the treatment, like early start of the treatment, proper engagement in the treatment, and the absence of any underlying medical condition and healthy family atmosphere and support. So you start answering this question when she asks you, will he get better? I would like to ask you some questions in order to answer this question accurately. So tell me more about this life circumstances of the family. Any stressors, anyone around you to support you in taking care of him? How about his physical condition? Any concerns about his safety that you would like to share with me? And then answer her regarding the prognostic factors. The information which you are going to gather here will help you to do your formulation, which I have said The first line is simply the ADHD, which is the main the psychological problem without details. What you have mentioned in your formulation that you started to explain what is ADHD. You said that problem in attention, problem in the impulsivity, problem in the movement, and so on. No, just say what is the problem now. The main psychological problem is that he has ADHD, which is affecting his education, potential risk if not managed. And the second line is the background information which you know or you need to know in the biopsychosocial areas and the level of risk, biopsychosocial areas of the patient. So all this in the background of having no physical disorder, no past history of psychiatric disorder, and has good support. However, there is a positive family history of ADHD. How did we know that he has no physical problems and there is no psychiatric problems and good social support? Because when she asked us before that, will he get better? We started to ask her some questions here in order to make sure that we are going to answer her accurately. And her answers helped us also to do a better formulation. It needs some skilled doctor to talk with the patient, to gather information from him, and which will help you to answer the question and will help you further on with the other questions.
Yeah.
Now, when you reach the management, as I said, when you start talking about your management, you only have 90 seconds, 2 minutes maximum. As I said, you should be very organized. First thing, what are you going to do, Dr. Anisha? I will follow him up in the child and adolescent clinic. So this is where the patient is going to be treated, and what are you as Dr. Anisha will be doing. Okay. Second thing that you want to do some blood tests, particularly the weight gain and height, to make sure that he is going to be safe when he takes his medication. So the investigations are routine, CBC, LFT, KFT, blood chemistry, and we add to them the weight gain, weight and height in order to make sure that he will not be safe when he starts taking the medication. The third line is talking about the particular team which will follow the patient. Here we have the adolescent team which will cover all his needs physically, psychologically, and socially. Now, psychologically, the backbone here is the stimulant, the methylphenidate. When she asks you about the side effects, common side effects like abdominal discomfort, headaches, you know the side effects. Now, a common question here, the candidates which find it difficult, does it affect the liver? I don't know why they are instructing the role players to ask this question, does it affect the liver? So methylphenidate is safe for the liver. However, there is another medication which could be used called Strattera, which has been linked to liver problems. However, Robin will be closely and clinically monitored after the start with the medications to make sure that he will be safe. Any special diet, also a very common question. There is no definitive ADHD diet. However, adopting a healthy eating habits is the best way to elevate the mental and physical wellness of the baby. Increasing the intake of fruits, vegetables, whole grains, and healthy proteins while limiting sugar, refined carbs, and saturated fats. Okay, so this is the best answer. These two questions often come in the stations and the candidates find it difficult to answer. Now, very important here in this station is the social part of the management, because there is family psychoeducation, and very important that you contact the school special education coordinator to inform him that this child is having ADHD. Again, school special education coordinator. You will not find this in other stations, other notes, so write it down. Okay, and physically, regarding the physical condition, you will liaise with the GP to explain the condition of Robin and the possible side effects of the medications. So this is regarding the management. Okay, any questions?
No, sir. It's really helpful.
Okay, so let's see according to our mark sheet rapidly. Again, don't be frustrated. It is only just to help you to understand how you are going to be scored. You are very clever, very experienced, but it's all down to this mark sheet. So whether you are following up my notes or any other notes, please make sure that your performance cover the points required from you in the mark sheet. Your formulation could have been better, so this point might or might not be scored for you. You recognize the significance of findings and results. The management plan, your management plan only included the medications. I did not hear from you that you mentioned the investigations. You did not mention the social or the physical part of the management. You did not mention the adolescent team or follow-up in the child adolescent clinic. So I don't think that this point might be scored. Does not pay sufficient attention to the patient health view. So I felt sometimes that you were lecturing, so this might not be scored for you. Risk management plan, again, because you did not talk about investigations, so this point might not be scored for you. The psychological social interventions, I feel that you are very clever, but as you can see, my personal opinion has nothing to do with the actual assessment. So this is a very common mistake which the candidates do. They feel that they are very clever and they said everything, but when it comes down to the mark sheet, as you can see, many points in the management might be lost. And regarding your communication, it was good. Your questioning style was good. However, because you were lecturing, you might lose one of these points. You can use poor language, for example, or you were very formalic, you're not having a one-to-one conversation, and so I think you might lose 1 point of the communication. So though you are very clever, Dr. Anisha, I feel that you have a lot of experience, a lot of background information, but you must understand what is required from you in the class in order to pass. Don't dwell on your experience, please. Okay, thank you so much. I hope that you found it helpful. Don't get frustrated. You might, okay? Okay, thank you so much. Okay, so who would like to go next? Dr. Noura, yes. Assalamu alaikum, Doctor. So what is your station, doctor?
Refeeding syndrome.
Refeeding syndrome. Yes. Okay, so this is refeeding. Very common. You have 2 minutes, just write down your notes and arrange it.
Okay, can I start?
Okay, so let's say that my name is Michael, and this is the patient whose name is Michelle. Okay. 1, 2, 3, go.
Hello, Michelle. I am Dr. Hassan, one of the psychiatrists working here.
No, my name is the nurse is Michael, and the patient's name Rachel. Rachel. 1, 2, 3, go.
Hello, Michael. I am Dr. Hassan, one of the psychiatrists working here.
Hello.
I understand that you are here to discuss that you have concerns about your patient, Rachel, and I'm here to help.
Yes, doctor. She has been doing fine. She has been diagnosed with anorexia. I've been following her up after her discharge from the hospital, but in the past 2 weeks, she is not good at all.
Can you tell me more about her condition now?
Well, she is not well, doctor. I feel that her blood pressure is not good. She does not seem to be looking good. I feel that she is, her hands and feet are swollen, and she can hardly swallow food also.
To understand the situation more, can I ask you some questions about Sarah?
Yeah, okay. Okay.
There is any blood investigation done for her?
No, as far as I know that she did all the investigation, everything is okay except for the phosphate. It seems to be a bit low.
Yes, I understand. Did she follow the GP recently?
Well, we did for her some investigation in GP, that's it. So,
Yes. Are you aware that she has any other physical health condition?
no, she has been discharged from the hospital about 1 month ago when she was able.
Yes. And does she follow a dietitian?
No, actually, no.
Okay, I can see. Thank you for this valuable information. From our discussion, it seems that Rachel has a medical condition called Refeeding Syndrome. Did you hear about this before?
No, what is the refeeding syndrome?
Yes, I will explain it to you. As you know, when Rachel was in starvation, her body depended on protein and the fat as a source of energy. And when she returned back to eat, her body returned to use the carbohydrate.
Yes.
Are you following me so far?
Yes, yes, yes.
Yes. And can you tell me, she didn't follow a dietitian, but are you aware about the weight she gained recently?
Well, she was gaining a lot of good weight, about 2 kilograms, because her mother is very cooperative. She is keen to make her eat as much as possible in order to gain
Yes,
weight.
and this is the point in refeeding syndrome, that she gained a lot of weight in a very short period. And when the body received this a lot of food in short period, he began to secrete a lot of insulin and consume a lot of electrolytes. The rate of
Why she is not able to swallow food?
Because as you mentioned, she has low phosphate, and phosphate is very important for action of muscles. Are
I
you
see.
following me so far?
Yes, yes. And also her blood pressure is low.
Yes, because of the electrolyte imbalance she has, and maybe she has low phosphate. We will do some investigation to be sure about the other things. Yeah.
So how we can help her then?
First of all, it's a serious condition, so we need to admit her in the medical ward, and even she may need ICU. The second thing, we need to make more blood investigation, including CBC and electrolytes, liver function, kidney function, and heart racing. Are you following me so far?
Yes, yes, okay, yeah.
Yes. Second, third, we will treat her in a holistic approach. This will include dietitian and physician and also the psychiatrist. Are you okay with me?
Okay, yeah.
Yes. When she improved and her physical condition become better, the dietitian will be sure about not increasing weight above half kilogram per week.
Yes.
Yes. And also she will need to be educated, her and her family, about her condition to avoid repeating this condition again.
I see. I see. I see. Okay.
Do you have any other concern?
No, thank you. Thank you.
Just to recap, we discussed about Sarah, who is diagnosed with refeeding syndrome, and she is physically unwell now, which carries a high risk if not treated properly. All of this on the background of having a good social support, as you mentioned, her family is caring, and also she has no other health condition.
Okay, okay.
Okay.
Okay,
Thank you for meeting me, and I'm here to help you.
So how do you feel about what you did? Give me a feedback, please.
Yes,
Give her feedback, please, doctors. Yes.
Because I know she's a refeeding syndrome, I forget to ask about how she gained much weight at the beginning.
Yes.
And I asked it later. Yeah.
Yeah. Okay. So how about your formulation, doctor?
Yes, formulation. My formulation at the end, it should be before the management.
Yes, exactly, exactly. Good that you know the areas which you should work on. Okay, so it is a very simple station, and the trick here is not much in the management as much as you show that you know how to talk with a colleague, a nurse, and take a hand over. So what is the handover? You want to know information from the patient about the patient regarding the biopsychosocial information and level of risk, and some information might be needed regarding the particular diagnosis also. And it is very important also to know what are the management steps taken so far. So this is how you start the patient. Okay, so in the beginning, you want to know more about in order to take the right clinical condition. Okay, so you ask her physically, what about her general condition of blood pressure, pulse, temperature, respiration? Is she able to go to the bathroom? Does she have any underlying medical problems? And if she is taking medications, and what are the management steps taken so far? Very important to ask this question. You want to know if there is any sort of management done so far, whether she has been assessed by the GP, any investigations done, and so on. Are you with me, doctor? Okay. Okay, doctor. Any questions? Okay, so after that, you will ask about the psychological. Since when she has been diagnosed with the anorexia? What about her current weight? Very important to understand more about the psychological condition. So you want to know more about her current weight, whether she is following up with a dietitian or no. What about her mental state, any depressive symptoms or psychotic symptoms? Very important to ask these questions. As I said, this is how you start this station, and this is the trick, or this is the part which the candidates don't know that before going through talking about the management of the refeeding syndrome, which is simply going to the hospital and taking fluids and vitamins, etc., you must show that you know how to take a handover. So we started by asking the nurse about the physical condition, now the psychological condition, and finally the social part of the management, the information, any social stressors around her. How do you describe her family? Very important, because when you ask this, you will understand that the mother is very keen to help her, but in a very non-professional way, and this has resulted in her complications. Okay, now we explain the diagnosis. You explained the diagnosis very well. Changing from the source of energy from fast to pure, this creates chemical imbalance, change in the blood electrolytes, and the level of phosphate, magnesium, potassium, and thiamine decrease considerably. Okay? And that's why the patient will have weak muscles, and this will include the muscles of swallowing. That's why she's not able to swallow. And also the muscles of heart. That's why she has low blood pressure. Okay? And also this can lead to kidney dysfunction, confusion, and salt water retention. Now, please formulate. So this is a case of refeeding syndrome, and I don't think that it will be very difficult to formulate. So can you formulate, please, Doctor?
Yeah, as I formulated at the end, it was okay or not?
You formulated at then, no, you should, the place of the formulation is before talking about the management, because the formulation is the foundation of the management. As I said, the formulation is simply picking up the most important points which you are going to work on in your management. So its place should always be before the management. So please try to formulate.
Okay, just to recap, we discussed about Sarah, who was diagnosed with anorexia nervosa, and she is currently unwell and has a condition called refeeding syndrome, which carries a high risk if not treated properly. All of this on the background of having a very social support, very good social support, and no other health condition.
Very good, very good, very good, very good. So as you can see, very simple. However, if you don't do it, you might lose points. Now, as I said, always start by saying what are you going to do and where the patient is going to be treated. So this is a refeeding syndrome is a medical problem. So she must be transferred to the medical ward, and you must say that you will see her there to assess her medical condition and to discuss her condition with the physician. So it's not only sending her to the hospital without doing your part as a psychiatrist to explain the condition and to liaise with the physician staff. Now, regarding the investigations, you will need blood tests. Very important to talk about the blood tests. The blood electrolytes, kidney function, liver function, heart tracing. Very important to mention this. Unfortunately, you did not mention this. So you want to know that you already mentioned that because of anorexia nervosa problem, she has refeeding syndrome, which is primarily a problem of electrolytes and chemical imbalance. So you must mention the blood electrolytes, kidney functions, liver functions, and heart tracing as a sort of investigations which are required. And the backbone here is you must mention what are you going to do or what will happen there is to improve the general condition and the vital functions and gradually correct the electrolyte imbalance and giving her vitamins like thiamine. Please mention this. So the backbone here is to correct the general condition, improve vital functions, correct the electrolyte imbalance, and giving her vitamins like thiamine. This is the main course of management. Now, after the discharge, there will be a team which will cover all her needs physically, psychologically, and socially. Okay, physically, the GP must understand that this patient has particular problem, psychological problem, which carries the risk of refeeding syndrome, and you must discuss this with the GP. Psychologically, you must follow her up regularly in your clinic to do everything regarding the risk assessment and the mental state, and to make sure that she's following up with a diet plan. And it's very important to educate the family. Socially, her diet must be supervised by the dietitian, so on, in order not to gain more than 0.5 kilogram to 1 kilogram per week. Okay, so this is regarding the management. So let's see again the mark sheet. Formulation, unfortunately, your formulation was not good. You did recognize the significance of findings and results. Unfortunately, your management, when you only said that she's going to go to the hospital, but you did not mention what will happen there. So you must mention that electrolyte imbalance, the investigations, and thiamine fluids, etc. Paid sufficient attention to the patient health view. As I said, you must make sure that you cover this point by saying that I will see the patient in the hospital. After discharge, I will follow her up to make sure that she is following up her diet plan and the management and address her concerns. Now, risk management plan, very good. You said that this is a very serious condition and she must be admitted to the hospital. Yes. Identify appropriate psychological and social interventions. The psychological and social interventions you did not mention. Only the social, because you talked about the dietitian, however, the psychological you did not mention. It was organized, everything regarding communication, I don't think you have a problem with, but from the management, you might score 2 or 3 maximum. Okay, I know that the management task can be frustrating. It needs practice, so don't be frustrated from my feedback. Okay, thank you so much, Dr. Nora. I hope that
Thank you.
Okay.
Thank you.
Okay, who would like to go next?
I would like to go, sir.
Dr. Raj. So what is your station, doctor?
Postnatal depression. I didn't understand whether it is management or history.
Okay. Okay.
Yeah, I can see.
Okay, ready?
Yes, sir. Ready.
Let's say that my name is Mr. White and my wife is Mrs. White. Okay.
Right. Good evening, Mr. White. I'm Dr. Raj. I'm one of the psychiatrists working here. Thank you for coming to meet me today. I understand that you're here to discuss about your wife, Mrs. White. Am I correct?
Yes, I'm very worried about her. I don't
I
know
understand.
what's wrong with her and that she can be treated at home or no.
Okay, I understand. It might be a really difficult time for you and your family having Mrs. X going through these problems. So as I understand from the GP's notes, and I have assessed your wife's condition at this point, and she seems to have some depressive symptoms, and she's worrying about her son. So before us proceeding with the discussion, I just want to check with you. What can you tell me a little bit more about her condition at this point?
Well, she has been, she was saying most of the time she is talking that she is not a good mother and she feels hopeless and she's not
So
able to change
I cannot
what's
hear you
happening
clearly.
to the child. What?
I cannot hear you clearly, sir.
She always tearful and she's talking about saying that she is a bad mother and she's talking about her child having leukemia. I don't know what's going on, doctor, actually.
I understand it can be quite difficult for you to, I mean, face these situations. And I'm here to explain to you what's happening with her. So can we have a chat around that?
Yes, okay.
Okay, just wanted to have a quick check here as to before, I mean, how long has she been feeling this way?
Well, I think she has been not well for about several weeks, doctor.
For several weeks.
Maybe 4 weeks now.
Oh, okay, for 4 weeks now. Okay, so based on our assessment, we have diagnosed her as a case of postnatal depression, also known as postpartum depression. Have you come across this term any time before?
No, what is this?
It means that she's having intense sadness of mood and related changes, which happens to ladies after after delivery of a child. So we understand that this is what he's having at this point.
What is it common, doctor?
It is, I would say that's not uncommon. It's fairly common, and 1 in 8 ladies after the delivery can have this.
What could be the cause of this postpartum depression?
I mean, there are many reasons for it. For example, for anybody who's having a history of depression in their past, for example, before them getting pregnant, that is one thing. And the difficulties that are associated with the pregnancy, having a difficult pregnancy or a difficult delivery per se. So these all can also lead to these symptoms. Having another family member, like in her case, I understand that her mother had depression before. So that can also act as a cause.
Okay. So if there is any risk because of this disorder?
What you asked is very relevant. I mean, since there are risks associated with it, because as she's 10 weeks pregnant at this point, and as the pregnancy progresses, I mean, she can this symptoms can worsen. That is one concern, but we will definitely be monitoring her. And and her health, for example, she can, if the symptoms intensifies, we have to monitor for her. She developing any kind of risk, she thinking of harming herself, or maybe after the delivery, I mean, how she's able to look after the baby, and whether she's able to, I mean, look after the baby well. These are the things that we will keep in mind.
Well, if do you think that she's going to be admitted to the hospital?
we have to consider that we have to, in the sense that usually in such situation, we can manage postpartum depression well with medications, but we have to keep her under kind of a close regular monitoring. And if we think that her symptoms are intensifying, and if she's not able to look after herself well, or the worry that she's having now is becoming more, then probably we would consider admission.
Okay, so but if she's admitted, who's going to take care of the baby?
Yeah, that's what I'm. Okay, you're asking about your son, right?
Yes, the baby.
Right. Okay. May I know just what's his name?
Robin.
Okay, Mr. Robin. Yes, if in a situation where we are deciding about admitting her, we can make arrangements for the Robin to be with the mother in the mother baby unit.
I see. What is? Do you feel that she's going to get better?
Yes, we are hopeful that she would get better with prompt and proper treatment.
I see. So how can you help her?
Yes, so at this point, we have to consider her addressing her situation in a holistic way. This will involve considering treatment with medicines, psychotherapy support, that is talking therapy support, and providing other support in the social way. Shall I discuss with you the medicines? Yeah. Would you like me to discuss about the medicines?
Yeah, no problem.
Yeah, we treat such symptoms with the medicines known as antidepressants. One of the common medicines that we use is sertraline. Have you heard of that?
No, what is it?
Right. Okay. And other factors are we can get in touch with the psychotherapy, that is talking therapy services. Those people can talk to her so that her excessive worry about the Robin having a difficulty, that can also be addressed. And you and your other family, your mother, her mother, I understand that you are really supportive towards her, and we would like you people to continue to be supportive towards her during her throughout the pregnancy.
Okay. How can I help her?
Yeah, as I said, be available to her to talk, if she wants to talk to, be provide support, provide.
Okay, okay, it's time. How do you feel about what you did? Please give me your feedback, and please give him some feedback, doctors.
I was not fully prepared for this, so I was just going as the question comes. I didn't have the exact answers as to the questions that you were asking.
Okay, Dr. Sarah, you're going to do your station after Dr. Raj. So now, please, doctor, pay attention to. Have you ever went to the council before?
No.
Did you? No, this is your first time?
Yes.
So pay attention, please, to the feedback, because you must understand what is required from you. Okay. Now, please use short sentences. You are talking too much. And while you are talking, you are stuttering, and you give me an impression that you are not very confident, because I felt that you were searching for the words. Please try to use short sentences. Now let's see, according to the, not this station. Now, this is not the station, not this station. I'm not very good from this issue, so give me some time. So, in the beginning, you had a good introduction. Your explanation was good. That it is 1 in every 80, very good. And then what could be the cause of postpartum depression? I think you mentioned most of the possible causes. but please, you can add some of them like social factors like mother for the first time, social stresses, weak support, some physical factors like cesarean section, complicated pregnancy, illness in the mother or baby. So you mentioned very important causes for postpartum depression, but please add 2 or 3 causes. If there is any risk because of this, so definitely there is risk, but you did not understand the risk in the sense that it is actual risk on the mother. It's not risk of a relapse. It is actual risk on the mother and the baby. So if left untreated, her mental state can be risky on herself and the baby and the pregnancy. Okay, so pay attention to this. You answered about when I was anxious or worried about who's going to take care of the baby, that the patient is going to be admitted to the mother and baby unit. Is good. Is she going to get better? Now, this is a question about the prognostic factors. It is a very common question which you are going to get in all the stations. So what are the prognostic factors? Okay. There are factors which favor the good outcome, like early start of the treatment, absence of psychiatric history, absence of physical problems in her and the baby, absence of stresses and good support. However, we know that her mother had a postnatal depression before, which is not in the good one of the good factors. Okay, but before saying these factors, you want to ask him some questions because you need to know some information which will help you not only to answer the prognostic factors, but also to do your formulation. So when he asks you, is she going to get better? You can say to him, in order to answer this question, I would like to know some information in order to answer it accurately. Can you tell me more about her social circumstances, any stresses, anyone around her to support her? How does you feel about the pregnancy? How is her child now doing? Is she able to take care of him? How about her physical condition? Do you feel that there are any concerns on safety concerns about her baby? Okay, and then list your prognostic factors according to the information given to you. Now, when he asks you about how we can help her, this is the best place in which you start to say your formulation. There is the first point which is going to be scored for you is your formulation, but at the same time, no one will ask you what is the formulation. Okay, so the best time to say your formulation is just immediately before talking about the management. So when he asks you how we can help him or how we can help her, you can say something like, before going through how we can help her, I would like to highlight the most important points which we will focus on in our management. She has postpartum depression with psychotic features, which poses risks on her and the baby. So this is the first line in your formulation, which is the diagnostic, the diagnosis, the psychological diagnosis without any historical details. Is postpartum depression, so with psychotic features, and there is risk on her and the baby. The psychological problem and the level of risk. This is the first line, and the background. The second line is the background information in the biopsychosocial area. So all this on the background of having a family history of postpartum psychosis in her mother. However, she doesn't have any past history of psychiatric history or physical problems, and she has a good support. So this is how you do your formulation. There are many ways by which you can do the formulation. There is an academic formulation, which can be very lengthy, definitely. This is not the place for the academic formulation. But you must show the examiner, as a member of the Royal College, you are able to pick up the most important points in the story of the patient, which will be the foundation of your management, okay? Now the management, what are you going to do, you, Dr. Raj? The first thing which you should do is talking about what are you going to do and where the patient is going to be treated. So you must see Mrs. Brown or Mrs. Green yourself in order to explain her diagnosis and address her concern. Please don't talk about the patient as if it does not exist as a human being. You are going to send her there and put her there and give her medications without talking with her to explain the diagnosis and address her concern and also explain the management. Okay, and you must mention that because of the level of risk, she's going to be admitted to the mother and baby unit, and she's going to be followed up by the perinatal team. So this is the first line. What are you going to do and where the patient is going to be treated, which you did not mention. Investigations. You need to know more about her physical condition because you are going to start her on medications. So how can you do this? By the routine blood test, but you must mention, you must name these tests like liver function test, kidney function test, etc. Okay. Number 3, you must mention the name of the team which will follow your patient. Here, it is the perinatal team, and this team is going to follow up regarding her psychological, physical, and social issues. Psychologically, you mentioned only the I don't know why did you choose sertraline. For me, fluoxetine would have been a better option because it is safe in pregnancy. But in addition, you must also add an antipsychotic which is safe in pregnancy, like olanzapine, which you did not mention. Very important to talk about an antipsychotic in this patient. And you must talk about the liaise with the obstetrician. This is a pregnant lady. She is on medications, and the obstetrician must be informed about the your management. Now, social intervention, once her medical condition is stable and is safe to go home, she will be discharged and followed up by the perinatal team at home. So this is your management, the psychological, the physical, and the social. When he asks you, how can I help her? This is more like a communication question. Your emotional support and helping her to be committed to the management plan is very important. Also, giving a feedback to the treatment team will help in taking the right clinical decision. Okay, so Dr. Raj, I think you have a question here.
Yes, I have a question here. In the initial the question of the task I had. So there was in bold it was written that she worries about her son. I had this
Yes.
doubt that I have assessed her. In nowhere in the text it was written that there's psychosis per se. Okay, depression was there, so I took it as depression with kind of an anxiety, simple worry. So where do I have to decide, or how will I decide?
Yeah, she expressed her worry that her son is having leukemia. This is not worry. She is worried that her son is having leukemia. Why is he having leukemia? A delusion is a false fixed belief which has no evidence. Okay, no evidence. Subculture or subculture. Okay, culture or subculture. So this patient is having depression or psychotic features.
Okay.
Okay.
So
I'll not go through the mark
do I
sheet
need
again
to,
for the sake of time. Now, what?
so I have a doubt. Do I need to kind of cross-check that with the husband that, okay, like have you people spoke to her? Is she fully convinced that son has got this? Do I need to kind of cross-check whether it is delusion or not? Should I directly consider it as postpartum depression with psychosis?
No, just say you are not here to check the historical details to explain to make sure the diagnosis is so and so. This lady has depression or psychotic features, and that's it. Okay.
Okay.
And when you explain the problem, you explain the depression and also the psychotic features. Okay.
Got it, sir. Thank you.
Okay. So as you can see here, it can also be associated with psychosis. Now, in your explanation, you explain that she has postpartum depression. It can also be associated with psychosis, okay, like her feeling that believing that her baby is having leukemia and so on. I'm not going to go through the mark sheet again, just for the sake of time. Okay, thank you so much, doctor. Who would like to go next?
Yes, please, doctor.
What is your station?
Post-MI depression.
Okay, give me 1 minute.
Okay, doctor.
Okay. So let's say that
what's
my
that?
name, I'm
Yes.
Robin, and the patient's name is Mr. White. Okay.
Okay.
Okay. 1, 2, 3, go.
Hello, Mr. White. I'm Dr. Halal from the Mental Health Unit.
I'm the nurse, student nurse, Robin, and the patient's name
Okay.
is White. Please don't do this mistake. You must understand the context
Mm.
in which you are going to be in. You are going to talk to a student nurse about a particular patient. The student nurse is Robin, and the patient is Mr. Robin. Again, 1, 2, 3, go.
Hello, Robin. I'm Dr. Hilal from the Mental Health Unit. I understand that you have concerns about Mr. White's condition. I'm here to help.
Yes, doctor. I don't know, doctor, what's going on with him. He's not keen to be involved in the management plan, and I would like to discuss this with you.
Yes, I understand. Well, from assessment, it seems that Mr. White is having what we call post-MI depression, post-myocardial infarction depression. Have you heard this term before?
No, what is this post-MI depression?
Post-myocardial infarction depression is a mood disorder that happens when people have depressive symptoms after having myocardial infarction. Okay? It's
I see.
actually, it happens in 20% of myocardial infarction patients,
I
and
see.
it carries a risk of increasing the risk of mortality, especially in the first 6 months.
I
All right.
see.
Unfortunately, it's often underdiagnosed because it's of its atypical profile and people interpreting the symptoms as a natural reaction to having a heart attack.
Okay.
So it's
Could
often
there be
underdiagnosed.
could be there any other reason for this low mood?
There could be a number of reasons, like an adjustment disorder, for example, or a relapse in a previous depressive disorder, especially with the stress of the heart attack. However, because of the close temporal relation between the heart attack and the depressive symptoms, it's more likely to be post-MI depression.
How can the myocardial infarction cause depression?
There are a number of reasons, but one of them is the stress and the increase in inflammatory markers, which increases the likelihood to have depression. Is that clear?
Yes, yes. Well, how about could depression cause myocardial infarction?
Yes, there is also a number of factors, including inflammatory factors and the stress causing myocardial ischemia, also adrenal related reasons,
Okay.
and also psychological factors. So there are an interaction between multiple factors. Does
How
it make
can we
sense?
help him? How can we help him?
Okay, so in order to help him, let me summarize the main points that we will need to work on. Mr. White has post-myocardial infarction depression, which could be risky if not treated timely. This is with a background of not adhering to his cardiac rehabilitation program, and we will need to know more about his social factors and social situation.
I see.
Okay, is that clear?
Yes, yes.
All right, so how can we help him? I will
Yeah.
follow up with him in the outpatient clinic to know more about his condition and explain his condition to him and his motivation towards the cardiac program. We will withdraw blood tests like kidney and liver function tests, blood coagulation profile, and heart racing.
I see.
And then there will be a team following him up physically, psychologically, and socially. So we will liaise with his physician and GP to discuss the medications he will be on. And as for his depression, the backbone of treatment would be an antidepressant from the SSRI group. Sertraline is recommended because it's the safest in cardiac patients.
I see.
He would also benefit from, sorry?
Any particular medications which should be avoided in his condition?
Yes, like TCA antidepressants and venlafaxine because of their side effects on the heart.
Okay.
All right. He could also benefit from talking therapies like CBT to address his negative thinking and behavioral patterns. As for the social aspect, social workers could help him and make sure that his rehabilitation period does not affect his work. Also, if he needs occupational therapists for to adjust to make sure that his work is suitable for his condition.
I see.
If he needs to stop smoking or quit alcohol, we can refer him to substance use services. And of course, we will help him adapt healthier lifestyle by following up with a dietitian and, if needed, maybe a physiotherapist. Does that make sense?
Yes, yes, yes. Very clear.
Do you have any other questions?
No, no, thank you.
Thank you very much. And I can give you my number if you have any further questions.
Okay, thank you so much.
Thank you.
Okay, thank you.
Good day.
So how do you feel about what you did?
I was a bit anxious and
Yes,
I
you're
stumbled
very
a bit.
anxious. You have all the information, but the way you communicate is very anxious. I think you have about 60, 70 seconds, not less than 70 seconds available in your time. But this is basically because it was one-side conversation. You're not keen to ask me, did what I said make sense? Are you following up? You're just giving me information.
Okay, yes.
And now, can myocardial infarction cause depression, and can depression cause a myocardial infarction? I feel that you have read the papers, my notes, but you were not able to give a very clear answer. So pay attention to this.
Anxiety.
Yeah. You are lecturing, actually, not having a dialogue. Pay attention. It's not about giving information. It is about having a dialogue with a colleague. Now, when you talk about the medications, avoid the abbreviations, which can, as a psychiatrist, we understand them, but we don't use them in the task. Like tricyclic antidepressants, we don't say TCAs.
Okay.
Okay. Okay.
Okay.
So let's see according to our sheets. Let's see. So in this station, you have another scenario. The outline of the management is the same, however. So the other scenario says that this is a 50 years old man and he's a teacher, demanding job. So there are a lot of social issues which you should pay attention in your management. He has a depressive symptoms of 6-7 months duration, and he is also smoking and is drinking beer, no exercise, and is not following out the rehabilitation program. So all this should be managed in the social part of your management plan, particularly the issue of communication with his job to make sure that the rehabilitation program is not going to affect his job. Okay. So in real introduction was very simple. Basically, the role player is a student nurse who doesn't have any information about the patient. So there are not a lot of things to take from him. So you go directly in explaining what is wrong with your patient, that he has the explanation, that he has a myocardial infarction and this post-MI 20% of the cases, okay? And they are past undiagnosed, as you have just said, because of the underestimation. And then could be there any other causes? A very common question which the candidates find it difficult. simply adjustment disorder, and also it can be another episode of depression. How can the myocardial infarction cause depression? A question which we can just find it difficult also. The stress which increase in the cortisol hormone, and you can say these medical terms because you are talking with a medical or nurse student. So for him, these medical terms are not strange. So the increase in the cortisol hormone, inflammatory chemicals, and in addition, there are some contributing psychological factors like existential crisis, feeling helpless and hopeless and unable to enjoy the life as before. So there is dramatic change in the patient's quality of life because of his new physical and medical conditions. Okay, now the very difficult question for the candidates: how can depression cause myocardial infarction? And unfortunately, many of the candidates cannot answer or don't know the answer for this question. So yes, depression can cause myocardial infarction. There are associated sympathoadrenal hyperactivity, and there is all this is definitely documented changes in the patients who have or have depression. There is associated sympathoadrenal hyperactivity. The platelets are activated, and there are inflammatory proteins, and also there is myocardial ischemia more than the controls in reaction to the stress. So this is how depression causes myocardial infarction, and this is how myocardial infarction can cause depression. So pay attention to this, please.
Okay.
How we can help him? I think you have just mentioned you did the formulation very well. Management. So very good. The best thing which you did, which definitely will give an impression about you in a very positive way, and that you are different from the other candidates, that you are keen to talk with your patient to assess his level of motivation, and also to understand why he is not engaged in this rehabilitation program. So you must understand the point of view of the patient. It's not simply from the outside, he has depression, and we are going to manage him as the depression, and everything will be sorted out. Talk with your patient, which you did very well. Okay.
Mm-hmm.
He is going to be treated at home. However, if there is high risk, he's going to be admitted to the hospital. Investigations, very important to talk about the INR and the blood coagulation. And as I said, there are routines and blood tests, liver function, kidney function, etc. But as for every station, there could be an additional blood test according to the scenario. Here is the coagulation profile. Okay, there will be a team which will follow him up physically. You must liaise with the physician and the GP to discuss the condition of Mr. Brown and the medications which will be used. Psychologically, the backbone here is antidepressants. According to the guideline, the best is the SSRI. Better to avoid tricyclic antidepressant, not TCAs. Please don't say TCA. And then venlafaxine. Okay. CBT now. Now, the social part is very important, and I think the social part is the thing which makes the candidates do not pass in this stage. Now, this is a man who has a heart problem, and you must also include a occupational therapist to make sure that his work circumstances now is suitable for his physical needs, and also the social services which will communicate with his work to make sure that the treatment will not affect his job. And also, it is very important that Mr. Brown is going to lead a healthy lifestyle, like follow up with a dietitian and enrolling in a subsidized gym under supervision of the physiotherapist, okay? And if there is associated problems related to the smoking or alcohol, he can follow up with the alcohol and substance misuse team. So the social part here, though it is myocardial infarction, and many candidates will focus on the medications, but unfortunately, the magnitude of the social intervention here is very, very important. And I think from my perspective, this is which makes the candidates in this stage. So let's see, according to the mark sheet, you did formulate, you did recognize the findings and the area management plan. Did you mention the social part, which we have just mentioned? Okay, very good. And you mentioned the medications. Did you say that I'm going to talk with you? Did you talk? Are you going to talk with your patient to address his concerns and so on? So point 4 is going to be scored for you. Risk management plan. Now, did you mention that if there could be a need for admission? If there
No.
is, so this might not be scored.
Okay.
The psychological, you did talk about the social, and I think you talked about CBT. So point number 6 can be scored for you. Now, regarding your communication, you are very anxious, and it appears as if you are lecturing. So point number 7 might not be scored for you. And it could be that you have poor listening skills, so you might lose 1 or 2 or maybe even 3 from the communication. Okay. I'm not an examiner, but I'm just helping you to understand how to use this mark sheet and also to pay attention to the particular areas which need to be improved. Thank you so much. Very clever, doctor. I hope that you found it out. So,
thank you.
Who would like to go next? Who would like to go next? Yeah, doctor. How are you, doctor? So what is your station?
Postpartum psychosis.
Postpartum. So I think you have some sort of echo in your voice, please.
Really? Is it better?
Yeah, yes, now. Okay, so we have here this.
Okay. 4 weeks ago. Sir, please, can you still scroll? I'm still reading.
You are ready?
No, no, no.
No?
Okay.
Same that my name is Mr. Brown. My wife is Mrs. Brown. Okay. So 1, 2, 3, go.
Hello, Mr. Brown. I'm
Hello.
Dr. Sua with Mental Health Unit. I
Hello.
understand that you have some concerns regarding
Yes.
your wife. Can you hear me?
Yeah. I want to know exactly what's going on with my wife. And she has changed, and she's totally changed, and you have to sit with her. What's going on?
Okay, I can see you are quite worried, but could you please tell me more about your wife? What is going on, Mr.
Well,
Brown?
she didn't have any problems during the pregnancy, but
Okay.
lately she became very emotional, and she's worried that the devil is out to harm the baby, and she's hearing voices telling her that she needs to keep her baby safe from the devil. Her husband, I noticed that she has been increasingly emotional lately, and what's going on with her, and she's not able to take care of the baby.
I'm so sorry to hear about your difficulties. So she gave birth 4 weeks ago, and since then you've noticed that she's weepy, she's hearing voices,
Yes.
and she's able to take care of the baby.
Yeah. Yes.
Can you tell me about her sleep?
Well, she's not sleeping well also.
Okay. Is she eating well?
Not as before, actually.
Not as before. Okay. You mentioned that she has been weepy. Mr. Brown, can you tell me more about her mood?
Well, I just said she is fearful and worried most of the time, doctor, about her baby.
Okay. And because she has been talking like this, has she mentioned anything regarding harming the baby?
Yes, well, she's talking about the devil, and I don't know, and she's not able to take care of him. I don't know why she's saying that the devil is going to harm the baby.
Hmm. How is I believe what is going on. She's hearing voices. She believes that the devil is involved, and she just put to bed 4 weeks ago. This seems to be a psychotic illness that occurred after giving birth. So it is called postpartum psychosis. Have you heard that before, Mr. Brown?
No, what is this postpartum psychosis?
It is postpartum because this is happening after giving birth. And she's having symptoms of hearing of voices. She believes that the devil is influencing the child, which is a belief, and she's holding on to it strongly. And apart from that, her mood is sad.
I see. I see, doctor. Is it common, doctor?
It's relatively common in women who have who put to bed. Maybe 1 out of 100 can come down with postpartum psychosis.
Okay. So what could be the cause of this disorder?
Mr. Brown, there are various causes. We have the medical causes and the non-medical causes. For the medical causes, we call them biological. One, it could be because she just put to bed. Two, it could be that maybe it runs in the family. And then it could also be if she has had stressful pregnancy, unlike the non-medical one, the psychological, a traumatic pregnancy delivery could also cause this. And then we look at the social parts. If there are issues with her support system, then all this could result in her having this. Or if she has had a past history if she has a past psychiatric history, this could also be responsible.
I see, doctor. So, well, what's the difference between postpartum psychosis and postpartum blues?
I didn't hear you.
What is the difference between postpartum psychosis and postpartum blues?
Oh, postpartum blues is very common. About 8 out of 10 women come down with postpartum blues immediately after giving birth. They are teary, but by itself, it resolves. But the postpartum psychosis is more severe, like the hearing of voices that Mrs. Brown is having and the belief that the devil is involved. So this is more severe and it lasts longer, and we need to intervene in postpartum.
Is there any risk from this problem?
Yes, Mr. Brown, there's a risk.
No.
Risk to herself. Mrs. Brown can hurt herself in the sense that she could become overwhelmed. Two, she cannot take care of her baby. She might not eat well. And because she's hearing voices, I need to find out if the voices are commanding. This can make her to do what, to hurt herself or to hurt the baby.
Okay. So how we can help her?
Okay, before we go into the management, I just want to highlight important points.
One minute. Yes.
That we discussed. Your wife, Mrs. Brown, just put to bed 4 weeks ago and subsequently noticed to be hearing voices and to believe that the devil has taken over the child, which we call postpartum psychosis. She has support from you, but there's no history of physical illness. So we are going to manage her in a biopsychosocial manner, which is holistic. The bio one is we will do investigations, but I need to see her first and determine where she'll be managed. Then there'll be a need to use medication that we call antipsychotic. Then the psychological part, there'll be talking therapy. Then the social part, her support system, which includes you, will be needed, and how she'll be managed when she's discharged into the community after the admission. So she'll be followed up in the community by the community mental health.
Time.
Thank you.
How do you feel about what you did?
I feel like I rushed. I didn't really read. I was not really able to finish the synopsis.
Okay, so first of all, you are using very long sentences. Please pay attention that you only have 7 minutes. And the time is challenging if you don't pay attention to the way you are talking and the way you are constructing your dialogue with the role player. Otherwise, you will always pass the 7 minutes. So the way you are expressing yourself needs to be changed, not because it is bad, but because it must fit in 7 minutes. Okay, you must be able to cover all the points in 7 minutes. Now, you used the biopsychosocial sentence. You said biopsychosocial several times. This can be, or I think will be, considered as medical jargon. We don't want this. We don't want to be considered using medical jargon. So let's see according to our yes. Okay, so now I think this is the so now this is our plan. You introduce yourself, you gather the biopsychosocial information, you explain the diagnosis, you do the formulation and then the management. So 5 steps, and under each step there are some things which you should do in order to make sure that at the end of the station you will cover the points in your mark sheet. Okay? You introduce yourself in very well way. You gather some information about her social circumstances. Pay attention that whenever there is some sort of pregnancy, ask about how does the patient or her spouse feel about the pregnancy, any support around them, any stresses. You must ask about the safety risk. So gathering the biopsychosocial. So biologically and psychologically, she has been already assessed. So the lacking information is the information in the area of the social and the risk areas. So gather information regarding the social and the level of risk, and then explain. I think you mentioned 1 to 2% of the patients who get the postpartum psychosis. No, it is 1 to 2, 1 in 2 out of 1,000 ladies. And it's okay. What can be the cause of this disorder? Always start by saying there is no particular cause, not saying that there are biopsychosocial like this. No, there is no particular cause. However, there are factors which increase the chance of having this disorder. Never talk about any psychiatric disorder with having a specific cause, very comfortable and very confident like this. There is no particular cause, but there are some factors which increase the chance of having this disorder, like having family history, first pregnancy, complicated pregnancy, very young or old when they are pregnant, sleep deprivation, and abnormal and hormonal and chemical imbalance. Okay. Now, risk, yes, definitely there can be risk from this condition on the mother and baby. Difference between postpartum psychosis and postpartum blues. He said that out of 10 patients, 10 mothers, 8 of them get postpartum blues. I don't know this statistical figures. As far as I know, that postpartum blues happens in 50%, not 80%. and resolves within 5 days after the delivery. The main symptoms are emotional lability, problems in sleeping and anxiety, and it does not last more than 2 weeks. Your formulation, I felt that, please, doctors, if you can mute your mics, please. Okay. Formulation. Okay, so let's see according to our the history and the information which we have. Please, when you say the information, your formulation should not include historical details. So this lady is having postpartum psychosis. Don't talk about hearing voices or delusions about the baby, just postpartum psychosis. And there is risk on her baby and on her and the baby because of her mental state. The historical details already mentioned, no need to add them in your formulation. All this of having no past history of family, the background of having no past history of family mental health issues and no stressors, and she's having no physical problems and good social support. So the background are the biopsychosocial information which she knows. Okay, is it clear, doctor? The formulation is a very simple skill, but please, you must practice it in order to make sure that you will score this point. Now, the management, what are you going to do, doctor? This is very important. As I always say, talk like a professional. Definitely, you need to talk with your patient before sending her to the hospital. So you must talk to your patient to explain for her his psychological condition, the management plan, and address her concerns. When you say this, definitely it gives a different impression about you to in the examiner's mind, because you are keen to talk with your patient. Not only this, there is a point in the mark sheet for those who talk with their patient, who are keen to address the patient's health view. Okay? And because of the safety concerns, she must be admitted to the mother and baby unit. Okay, so this is how you start talking about the management. What are you going to do and where the patient is going to be treated? Number 2, the investigations, as we have discussed before. Number 3, you must mention the perinatal team, which will cover all her needs physically, psychologically, and socially. Please avoid saying biopsychosocial. Use the term physical. Okay, it is less jargon. So there is a team who will cover all her needs physically, psychologically, and socially. Now, regarding the psychological, this is what you should start with. The backbone is giving her an antipsychotic, which is safe in her breastfeeding. And psychological, there could be also help from the talking therapy. Socially, when her mental state is safe to be discharged, she will go back home and will be followed up by a nurse to make sure that she is safe and also the baby is safe, and to detect the early signs of physical and psychological disturbance. Okay, so this is the biopsychosocial. Okay, are you with me, doctor?
Yes, thank you.
Okay. I'm not going to go through the mark sheet again just for the sake of time. Okay, I hope that you found it helpful. Pay attention to the feedback. So
Thank you.
who would like to go next?
I would like to go next if possible.
Yeah, no problem. Doctor, so who?
Swapanjit Sharma.
Yes, okay. So what is your station?
It's rehabilitation and psychosocial management for negative symptoms.
The psychosocial support.
Yeah. Actually, I haven't practiced this station ever before. This is a new one.
Okay, so Please read role players' notes only. Also.
Yeah, I'm going through it. This patient is having schizophrenia and also
Yeah.
depression together, isn't it?
Past history of depression.
But the current note seems that, yeah, a lot of depression is still there.
A lot of information, yeah.
And medication-wise, she is currently on clozapine.
Mm. Finished?
Yeah.
Okay.
So I'm talking to the patient, isn't it?
1 minute, please.
I'm talking to the patient itself.
Speak to the psychosocial. Speak about the psychosocial treatment options.
And with whom I'm talking? Is that with the patient or someone from the care home?
No, you are going to talk with the one of the carers, with the nurse, yeah.
The nurse, okay. But your note says that about the patient.
I'm going to talk with the patient. Sorry. It's the patient. Okay. 1, 2, 3,
Okay.
go.
Hello,
Hello, doctor.
I'm Dr. Sharma. Hi. May I know your name, please?
You can call me Rachel.
Hashan.
Rachel.
Hi, Rachel. Yeah. Hi, Russell. How are you?
I'm fine.
Well, I'm Dr. Sharma from the mental health unit. I'm here to know the difficulties that you are having because your care home staff are a little bit worried that you don't seem to be engaging much in the activities that are happening here. Are you willing to talk with me?
Yeah, no problem.
So it'll be helpful if I can get some idea what actually is going on with you.
Well, I've been discharged to a local resident home about 1 month ago, and that's it. What do you want to know?
Okay. And as I have gone through the notes that is presented to me, that in the care home, you are currently on clozapine. Am I right?
Yes.
Okay. And can I just check this? How is your symptoms of schizophrenia been there?
Well, it has been controlled by the medications, but I feel that I'm not thinking rapidly as before. I feel that my mind is slow.
Okay. And what did you mean by your mind is slow?
Well, I don't know. It seemed that I used to be more fast in understanding things, but now I'm not.
Okay. So you feel that you are not able to understand things as fast as you used to be, isn't that?
Yes.
Okay. And apart from that, how would you describe your mood, Rachel?
Well, not bad, not good. That's it.
And how would you view your future to be?
Well, I don't think that it was as bright as it used to be. I used to be an engineer. Now I'm stuck in rehabilitation
I'm so
unit. And I don't know what will happen.
I'm so sorry to hear all this. It must be hard time. Okay. And just to check on that, do you have any energy to engage with the rehabilitation staff here?
Well, there are some activities which I feel I can do, some I don't like to do. That's it.
Okay. Thank you, Rachel, for this information that you have given me. It's quite important so that you and me can develop a further management plan. Are you interested in knowing how we both can help?
Yes, no problem.
Thank you. So, at the very beginning, I would like to first go in with the notes of the care home regarding your treatment, the medical doses, or what investigations they had already done. That would be my first priority. And I'd like to do some further investigations regarding your thyroid level because that is a hormone that can impact your mood and your activity. Okay. And also
Okay.
I'd like to see, I'd like to see what medicines you are on because I feel there is some need to introduce some medicines which can impact your mood in a positive way because I only know about the clozapine that's going on here. So that is something which I would like to sit with you again in a separate session. But today I'm basically here to talk with you regarding what other things that we can do so that you can feel more engaged. Are you interested in knowing that?
Yeah.
Okay. So one thing is that have you just let me check it with you. Have you been offered any kind of talking therapy before?
No.
Okay. So I feel that is a vital part because there are a lot of talking therapies. Initially, I would like to go for something like letting you know about your disease, in fact, better. Something called psychoeducation. Okay.
Okay.
And as a part of the therapy, would you be interested in joining a group of other people who are going through the same difficulty?
Okay, no problem.
Yeah, that's quite nice, I feel, for you because that will let you introduce to other people who are having same difficulties. You can share your thoughts with them. There will be a guided instructor there, a psychologist who can guide you through how better you can be more active in your talking patterns, how you can incorporate basic ideas and be more fluent. How does it
Okay,
sound?
no problem.
Yeah, and the another benefit will be that you will be getting ideas from other people, how they are coping with their life stressors. That will put you a lot of interest in engaging into therapies. Apart from that, I would like to see what the social care department is already doing for in your case because I don't have much information there, and I feel there are a lot of things which can be done to improve your social interaction and your social care. Have anyone talked to you regarding this before?
No.
Okay. This is a very vital part of your treatment because you said you are an engineer, but currently you are not able to do your job, which obviously is a major life setback, isn't that?
Okay.
And I believe that you are very keen to go back to your engineering job.
I hope so. Yeah.
You hope, yeah, because you have said me you are very much interested, but you don't know how to go for that. You're not feeling motivated. So
Yes.
apart from your symptoms of depression, there are some help which can get you actually how to go about getting into your job again, how to approach the job persons who are getting a job. There are in fact avenues where we can place you in a supported job environment first, then on a later in a stepwise fashion, when you are gaining more confidence in a supported manner, you can be given individual responsibilities. Then your this is something which I'm calling regarding the social care department. They will employ someone called a
1
occupational
minute
therapist
remaining. 1 minute.
or someone who can look after your supported job and accommodation
Okay.
people. So they will help you in this manner by giving you phase by phase alignment to gain your job. And also, we would like to look regarding your housing arrangement back in your home, what has already been going on here, because you are not in your home for quite a long time. and also to give you a lot of stimulations in the way of a lot of games, engaging in group activities, singing groups, dancing groups, according to your interest. Okay, would you be interested in knowing these things?
Yes, definitely.
Because time is short, I'd like to come back again and discuss in more details if you're more interested in this. So hopefully I gave you some context regarding what you can do in a social way of managing your difficulties.
Okay.
Thank you for giving me this time.
Okay. Thank you. How do you feel about what you did?
I don't know much because I didn't have a
It is a very
clear
different
structure in my
station, a
mind.
new type, a new station, and actually the approach and the
Yeah,
passing rate is different, and the passing rate is very, very low in this particular station. So I hope that you pay attention to what I'm going to say. You will not find this information in other place except my note as far as I know. So if you want to take
please, sir.
screenshots, feel free. So let's see. Psychosocial support. So you start gathering some information from the patient, okay? Ask about the condition of the leading to the admission. And you want to know more about her psychological condition, the medications, perceptions, but it should be rapidly, okay? So are you taking your medications? Sometimes people who have schizophrenia can have some strange experiences. I'm wondering if you are experiencing any, like hearing voices, or seeing things which no one else can see. You feel that you are safe in the residential home. Anyone wants to hurt you. How about your mood?
Sir,
Okay.
how do you say, sir, that like I have asked one simple question that how are you doing on your psychotic symptoms? Will it cover or you have to go in more detail?
What do you mean? I'm just reading my notes. So what do you mean?
Okay. No, I asked you in the role playing that how are you doing on your psychotic symptoms? Is there any difficulty?
Okay, no problem. I'm just reading the notes. I didn't say that you missed it. I'm just explaining how you can approach. Okay.
Please.
And then you must ask more information about her social circumstances at the nursing home and the family. So the problem that she's not engaged in the activities. So you want to know, how does she feel about the nursing home? Can you take me through what you usually do in a typical day in the nursing home? Are you interested in the activities offered to you? Are you engaged in the people around you? Tell me more about what you are interested in, and etc. Okay, and you want to know some information about her family, and then you will understand that she does not have any family around her to support her. If you one question about her physical condition, and very important, doctor, very important, though this is a psychosocial support station, but still you must show that you are a safe practitioner and ask about risk, simply because there is a point in the mark sheet about the risk. So it is for those who are keen to ask about the risk. So I'm worried about you, Mrs. X. So any thoughts about harming yourself, or life is not worth living? Use any street drugs or alcohol? And while she's talking to you, the role player is instructed. Here, I don't know where it is. Here, it's written here that she must talk in a very monosyllabical way and very monotonous way. You must comment on this, because later on this will be important in your explanation of the condition. So comment on the paucity of speech. It seems that you used few words to express yourself, Miss X. And then explain the problem. So from the discussions, it seemed that she has negative symptoms. Have you ever heard about this, Miss X? This means that you have slow thinking reflected by the use of few words. This means alogia. Okay, you must say it. And this is the tricky part in this station, that you must explain to the role player what is the problem. He has negative symptoms. So he has alogia, as we said, and his mood is not very active, apathy, and not engaged in personal social activities called asociality. And there is low motivation, and she doesn't care enough for herself. It's called avolition. And she seems not interested in doing many things. These are called anhedonia. So this is very important in order to explain later on and to justify your approach to these negative symptoms. What are the negative symptoms which you are going to set a management plan for? You must explain them. Okay, so from our discussion, she has negative symptoms. Have you ever heard about them? And go on, explain the alogia, avolition, apathy, etc. And then you must do your formulation simply because there is a point for the formulation. For going through how we can help you, I would like to highlight the most important points in our discussion. You have resistant schizophrenia and depression, for which you are taking clozapine, fluoxetine. However, there are still negative symptoms and the risk is low. Okay.
Okay. Okay.
Sorry. All this in the background that she does not have any medical problems, that there is no social support from her family. There is no social support. This is how you formulate. Now, the management plan.
Okay.
Now, this is the tricky part, which the candidates unfortunately find it difficult to set the management plan. And though I know that you are very experienced and very clever, still you find it difficult because it is different from the other stations.
Yeah.
So when you start talking about the management plan, start by saying, what are you going to do? So I will follow you up regularly to assess your physical, psychological condition, level of risk, and to address your concerns. There will be a psychosocial rehabilitation plan to help to improve the quality of life by improving the brain functions and social functions, okay, which are negatively affected by the mental illness, okay? So your plan is to
Okay.
improve the quality of life by improving the brain functions and the social functions, which are negatively affected by the mental illness. Number one, there is cognitive enhancement therapy, something called cognitive enhancers done under the supervision of a cognitive enhancement coach. This includes computer programs to improve the attention, memory, problem-solving skills, and executive functions, okay? Are you with me?
Okay.
So this is the first step.
Yeah.
You use the cognitive enhancement therapy. Number two, social skills training, SST, also includes the improvement of use of verbal and non-verbal communication and improving the self-expression. This also includes group exercises to improve social skills and the ability to relate to other people. Are you with me, doctor?
Yeah.
Number three, vocational rehabilitation. This promotes good work habits and independence. The vocational rehabilitation.
Yes.
Number four, family intervention, psychoeducation about the illness and the proper ways to help the patient. And finally, CBT, which you note. Okay, so these are the 5 points which you are going to talk about in order
Very
to
important, sir. Yes.
address the task, which is the psychosocial. It is basically psychosocial. There is no
Biological.
medications, a lot of medications to talk about psychosocial intervention. Okay. I know that this can be difficult for many of the candidates because it's different approach, but when you practice it, definitely you will find it easy. So I'm not going to go through the mark sheet for the sake of the time. Okay, so who would like to go next?
I would like to go next, Dr. Surya.
So what is your station, doctor?
Schizophrenia and cannabis stopped olanzapine.
Yes, schizophrenia and cannabis.
Okay, can start. Yeah, can start. Hello. Yeah, I can start today, Dr. Hassan.
Now, this is the summary of a very long scenario and role players information.
Ah.
So I hope that you pay attention to what is written here, because what is written in our place will be very, very long without any more details. Okay, so we will start. 1, 2, 3, go. Let's say that my name is Robin and you are the doctor. Okay, 1, 2, 3, go.
I'm Mr. Rob.
1, 2, 3, go. I am Robin and you are Robin. I am Robin.
Hi, Mr. Robin. I'm Dr.
Hello,
Surya from Mental Health Unit. I understand that you're referred by your GP since he is concerned about your condition, that you have stopped your medication about 6 weeks ago. Could you tell me more about that?
Well, yeah, doctor, I did not feel very happy because of the medication, so I stopped it. And anyway, I've been taking it for a long time, so why should I take it again?
Okay. So could you tell me why did you stop taking the medication?
Well, it is a very embarrassing issue, doctor. You are a female doctor. I'm worried that you might not feel that it is appropriate to talk about this.
I can see that you're having some difficulty and side effect of the medication. So, okay, could you tell me more about your problem that you're having so that I can help you better?
Well, you know, these medications affect, the man, the ability to have proper erection, and I'm not happy with the side effect.
Okay. Thank you so much for sharing this, sensitive and personal information with me. Okay, I know it's difficult to share about, but it's something that we deal on a daily basis.
What?
So, something that we deal on a day-to-day basis. So I'm here to help you. So
Yes,
could you tell
okay.
me, okay, what are the difficulties that you are facing after you stop taking the medication?
Well, I told you, because of this side effect.
Yeah. Did you experience any strange,
Yeah,
strange
I
experience?
started to hearing the voices which usually comes to me. I don't know what to say. They keep whispering.
Okay. Apart from that, okay, do you have any other unusual things that going on?
Like what?
Do you have any like
Please raise your voice. I can hardly hear you.
feel as if like someone is harming you or hurting you?
No.
Sorry, I can't hear you.
What?
Okay. So good. How did you coping with all these disturbances?
Well, the only thing which helps me is to take cannabis, and that's it. It helps me. It calms me down.
Okay. Okay. And okay, so I just want to do you have any medical problem that I need to know of?
No.
And okay, I would like to know a bit more about your social support. Who do you stay with at the moment?
Well, I'm living alone. No one is around me.
Are you getting any support from anyone?
No.
Hello?
Yes.
Hello?
Do you hear me? Hello. Anyone, do you hear me, my colleagues, or she's only? Hello?
Yeah, we are hearing you, sir. We are hearing you.
Hello, we can hear you.
Yes, I think the
We can
problem
hear you,
is
sir.
from
Yeah.
her connection. Yeah, I think we lost connection with her. I will wait a few minutes, and if not, there is no connection, we will conclude this session. I'm very tired. I think she left. She is not there anymore. Okay, I think we can finish here. She's not available. Okay. So, no, see, she has joined now. She has joined.
Hello?
Yes, doctor. Can you hear me?
Sorry, the problem with my connection. Yeah.
Your
Can I?
voice is low, please. Your voice is low. I can hardly hear you.
Okay. Can you hear me now?
Yes, yes, yes.
Okay.
Okay, please continue from where you have stopped.
Okay. So, okay, who do you live with at the moment?
I'm living alone though.
Okay. Are you getting any support from anyone?
No, no.
Okay. But okay, have you ever felt it's so overwhelming and
What? What?
okay, there is a thought to harm yourself or end your
No,
life?
no, no, no.
Are you feel so overwhelmed? Okay. Thank you so much for sharing all this information with me. From what I've gathered from you, I can see that your schizophrenia illness has came back because you stopped taking the medication.
Yeah.
By taking cannabis in the and with social support.
Yes, yes.
So at this moment, okay, so I have some short-term plan and long-term plan for you.
Okay.
Okay, so in terms of long-term, hello, can you hear me?
Yes, yes.
Can I connect? Okay, okay. So in the long term, I would like to start a medication, okay, which is which is have better in terms of side effect profile and low sexual side effect. So we do have that option for you in the future, but in the short term, okay, I'm really concerned about your mental health. And
Yes.
okay, I understand you have responded well to olanzapine before.
Yeah.
Okay. And I would like to suggest you to take olanzapine again so that you get well in terms of your mental health as soon as possible.
Okay.
What do you think about that?
That's okay.
Yeah. Okay. And okay, to focus is about your cannabis usage.
Yes. Please raise your voice. Okay.
Okay. Okay, I understand that you need something for you to feel better and when you are alone and to distract you. But based on the research, it says that cannabis can affect your mental health and well-being.
Okay.
So I would like to refer you to substance and misuse services for your cannabis usage.
Okay.
Are you able to follow me so far?
Yes, yes.
Okay. And okay, the next good thing is I would like to attach you with the community mental health services so that the nurses can come to your house and monitor your compliance to the medications and to see how you're going in terms of your mental health.
Okay. Very good. Very clear.
Okay. Okay. So so we're gonna work as a team, okay, to help you with your current condition.
Okay.
Do you have any questions for me so far?
No, no, time. Okay. So thank you so much, Dr. Suraya. I understand that this session, your station was interrupted, but all in all, it was not bad. Please pay attention to the phone if you don't mind. I will share my sales. Okay, so pay attention to the following. The first thing, as we said, there is a plan in our mind. Whenever we see a management or address concerns, we do our introduction, we gather biopsychosocial information, then do his explanation or vice versa, according to the flow of the information of the station. We do our formulation, and finally, the management. Pay attention that this both take a history and management and requires a careful time management. The diagnosis already mentioned, you need to establish the relapse, the circumstances which led to the relapse, and the level of risk. So after the introduction, as we said, our second step is to gather the biopsychosocial information and the risk, and this is the area in which we are going to cover the history part. Okay, we start by the psychological. You want to know exactly what is the problem, what is the complaint, what is the current circumstances? Tell me more about your experience at your work. What do they do and why? Who is doing so? Could there be any other explanation? When did it all start? How did it start? So you want to take the complaint, and there is the rule for the complaint. The complaint is the current circumstances, the onset, the course, duration, and what happened before the onset. So the onset is when did it all start? How did it start? And the course, do you feel it is increasing with time? Anything makes it more inclined? Anything make them more inclined to do this? Anything prevents them from doing this? And when you talk about the course, he will say to you, whenever he's taking cannabis, he feels that the issue is improving. Okay, so before the onset, you want to know exactly how was he doing before the onset, and you will gather that before stopping the olanzapine, he was not happy because of the sexual side effects. Okay, and then the symptom syndrome. You ask about any other psychological problems like the hearing voices and so on. And if he is still interested in things he likes to do, the mood and so on. So the first thing is the psychological, the complaint, and the symptoms of the syndrome. Here we have the symptom syndrome is our schizophrenia, and ask 2 questions about them. Then the social, we said that the first thing you start with is psychological, then the social, the medical, and finally the level of risk. Okay. Here you must ask about the level of risk because he's taking cannabis, and he might have some thoughts of harming anyone else because of his delusions. Then explain your the problem to the patient, that he is having schizophrenia and it is relapsed because of stopping the medications and also taking cannabis. And you must say that if it is not controlled, there can be some sort of safety concerns regarding his safety and the other safety. And do your formulation, and simply this formulation that he has schizophrenia in the form of active hallucinations and delusion, and there is risk if the symptoms are not managed, all this in the background that he's taking cannabis, and stop the medication due to sexual side effects. Okay. Now, our management, when you start talking about the management, for me, there is a particular pattern. We start by talking, saying what Dr. Soraya is going to do. You want to have another talk with him to explain for him regularly his mental state and physical state in the clinic. And there's a potential risk. If there's a potential risk, he might be admitted to the hospital. Okay. So you want to follow him up regularly in the clinic, and if there is any risk, there could be a reason for admission. Please, whenever you are going to talk about the medications, don't forget to talk about the blood tests, particularly the blood sugar level here. Say something which makes you different. We have 2 reasons here for sexual problems: the high blood sugar level and the prolactin level. Okay, so you must say something which shows that you are different. So it's not only because the direct effect of the medications, there could be the high blood sugar level or high prolactin level. Okay. There will be a team which will cover all your needs physically, psychologically, and socially. Psychologically, we have the backbone is olanzapine. But make sure that he accepts this. So how about taking olanzapine, which help you before to control your symptoms? And if there is any sexual side effects, we can add to him sildenafil. This is a justified use of this medication if the patient is having any side effects, sexual side effects because of the medications. And there is another antipsychotic called aripiprazole, which does not have the tendency to cause sexual side effects. Are you okay to start taking it? So give him options, either olanzapine, which has improved him, and if there is no if there is sexual side effects, he can still take sildenafil, or he can change the medications to another medication which has the low chance to cause sexual side effects. Now there is a place for the talking therapy, and socially there will be good to have an appointment. Good to have an appointment with alcohol, like you said, alcohol and substance misuse team, and there will be a nurse who will follow him up. This is a social, a psychological, and finally you terminate your station, and that's it. I hope that you found it helpful. Okay. Please pay attention to the feedback which I've given to you. You have missed some important points, like the use of aripiprazole if he refused the olanzapine, or use the sildenafil. Okay. Make sure that also you put in your mind that he might have the possibility of having high prolactin level or having high blood sugar level. Okay. I hope that you found it helpful, doctor. Okay, I'm very tired, so we can end here. I hope to see all your names in the pass list. Have a good night. Thank you.